Let's take a look at how prescription opioids might be misused, abused, or diverted. This slide looks at state-level data for drug overdose death rates, also known as drug poisoning deaths. These data from 2014 include overdose deaths associated with any licit or illicit drug, not just those due to opioids. In 2014, the age-adjusted national average was 14.7 drug overdose deaths per 100,000 population. The 5 states with the highest drug overdose death rates were West Virginia, New Mexico, New Hampshire, Kentucky, and Ohio. Furthermore, U.S. drug poisoning deaths in 2014, specifically involving prescription opioid analgesics, totaled nearly 19,000, or 5.9 per 100,000. We often use the word abuse in a general way to describe a variety of undesirable behaviors relating to prescription opioids. But the various types of abuse can be more specifically categorized as misuse, abuse, and diversion. Although there's a lack of consensus on the exact definitions of these terms, misuse is generally considered to be an intentional therapeutic use of a drug product in an inappropriate way. Misuse specifically, as defined by the FDA, excludes the definition of abuse. An example of misuse would be taking more than the prescribed dose of a medication because of breakthrough pain. Abuse is intentional, non-therapeutic use of a drug product or a substance, even once, to achieve a desirable psychological or physiological effect. Examples include taking multiple intact pills to achieve euphoria or a high, or tampering with the form of the drug, such as crushing it or snorting it. Diversion is the intentional removal of a medication from a legitimate distribution and dispensing channels. Diversion also involves the sharing or purchasing of drugs between family and friends, or individual theft from family or friends. Let's take a closer look at diversion for a moment. These data are from the National Survey on Drug Use and Health, a large-scale survey sponsored by Substance Abuse and Mental Health Services Administration, or SAMHSA. Contrary to what we may conclude from watching the news, relatively few non-medical users of prescription pain medications get them from drug dealers, rogue internet pharmacies, or doctor shopping. Instead, non-medical users reportedly get the medications from a friend or a relative, either given to them for free, through theft, or through purchase. In this survey, SAMHSA defined misuse as use in any way not directed by a doctor, including use without a prescription of one's own. Use in greater amounts, more often, or longer than told to take a drug, or use in any way not directed by a doctor. So the prescription you write to a well-intentioned patient may still wind up being abused by others. The bottom line is, despite all the precautions we take, we never know who may end up having access to a prescription after it leaves our office. Currently, there is no way to track and trace bottles or pills. Now, how does prescription opioid misuse and abuse actually occur? Well, here are some examples. Opioids may be swallowed whole in amounts other than prescribed. This is the most common way of opioid abuse overall. Or they may be crushed, then swallowed, snorted, or smoked. Or they may be crushed, then dissolved for the purpose of injection. Manipulation of a product is generally done in pursuit of a more intense high, resulting from a rapid increase in opioid levels in the blood. Note that the methods of abuse vary among products based on their pharmacokinetic properties, their bioavailability via different routes, ease of tampering, nature of euphoria produced, and the presence of dangerous excipients. However, in one survey, half the people abusing prescription opioids reported manipulating the form of the medication. This is more common with extended-release opioids due to the higher drug content than with immediate-release opioids. Also note that regardless of the formulation, all mu-receptor opioid medications carry the risk of abuse, since they all have the potential to produce euphoria. Oral abuse of prescription opioids take two forms: simple overconsumption of intact pills and consumption after chewing or crushing the medication. A recent analysis, currently being prepared for publication, examined the prevalence of various routes of administration of opioids used in the last 30 days amongst abusers entering substance abuse treatment. The investigators found that approximately 40% of oral abusers manipulated opioids before swallowing, and chewing was found to be the most prevalent manipulation method, used by approximately 35%. It's important to note that according to available data from an abuse treatment center, most people who abuse opioid medication by snorting or injecting it don't begin that way. In this study of opioid-dependent individuals admitted for drug rehabilitation, 83% reported that they had first used the prescription opioid orally. However, at the time of treatment admission, only 14% were still using the oral route. The rest of them were snorting or injecting. The mean duration of prescription opioid use in these individuals from initial use to treatment admission was about 19 months. Although oral abuse of prescription opioids is the most common, non-oral abuse is important to consider because it is more often associated with severe health consequences. In this analysis of poison center data, there were relatively few cases of abuse by inhaling or injecting as compared to oral misuse or abuse. However, the cases involving inhaling or injecting were more likely to result in a major effect or death. In this analysis, a major effect was defined as symptoms that were life-threatening or resulted in significant residual disability or disfigurement. These severe health consequences were approximately 2 times more likely with injection as compared to oral abuse. Furthermore, it can be very difficult to identify patients who might have a problem with prescription opioids, even though we may think we do it well. Take a look at the data shown here, which is from open-label, non-randomized, non-comparative study of 367 patients. All of these patients were confirmed to be high risk for opioid misuse and abuse based on the validated, revised screener and opioid assessment for patients with pain, or SOAP-R instrument. But when primary care physicians were asked to evaluate opioid risk in these patients without knowledge of the SOAP-R screening, they only categorized 5% of the patients as high risk. So clearly, going with our gut is not sufficient. We need to use validated tools and tested methods to assess and help reduce risk. Here's a more recent survey providing insights into the journey made by many legitimate opioid prescriptions. Researchers from Johns Hopkins recently published the results of a national survey of 1,032 U.S. adults who had used prescription painkillers in the previous year. Among respondents, 1 in 5 reported that they had shared their opioid medication with another person, with a large number reporting that they gave the medication to someone who needed it for pain.